Okay, so let's talk about some different types of cancer treatments. First of all, cancer may be treated surgically. Prophylactic surgery removes at-risk tissue to prevent cancer development. And an example of that would be a colon polyp. It's not cancer yet. If it's removed, it doesn't ever get to become cancer. Diagnostic surgery removes part or all of a lesion for testing. So they might do that in a suspected melanoma, for example. Curative surgery removes all cancer tissue. There's a 30% cure rate if all visible and microscopic tumor is removed. So curative surgery, the goal is to remove all of the cancerous tissue. Cytoreductive is to remove part of, but not the entire tumor. And it's often used to increase the chances that other therapies will be successful. So they may do surgery, remove as much of the cancer as possible, and then use other therapies to try to eradicate the remaining cancer. Palliative surgery is surgery that's performed to decrease symptoms and improve quality of life when a cure is not expected. Okay. And that doesn't mean that death is imminent. People can live with some cancers really for quite a while, and removing part or all of that tumor may improve their quality of life during that time. Second look cancer is re-examining after treatment to determine the status. Reconstructive or rehabilitative surgeries may improve function, appearance, or both after surgical procedure, after surgical removal of cancer. The risk and side effects of surgery in cancer. Think about all of the risk of surgery. You already know this. We did it last semester. You've been practicing identifying those risks this semester. So anything that can happen because of surgery, now we're taking those risks with a patient who may be compromised and have higher risk of all those things happening. Okay. Also, sometimes for cancer, surgery may lead to the loss of a body part or function. For some types of bone cancer, for example, they may have to do amputations. It can lead to scarring and disfigurement, and patients may grieve the loss of that organ or function, or a change in their appearance, or a change in how their lives will, in their life going forward. So that's surgery for cancer. Radiation is sometimes used to treat cancer. And this radiation is targeted to destroy cancer cells. But radiation also destroys and damages healthy cells. So the goal is to focus the radiation on the cancer cells and minimize the effect on healthy cells. Radiation can be used for cure, control, or palliation. The effects are only in the tissue that's within the radiation path. So those effects are not going to be in the rest of the body, but they can affect all of the tissues in the path of the radiation. So there are different delivery methods. Teletherapy is when a source is outside the patient. Okay, teletherapy means that during a radiation treatment, patient is set up, radiation is aimed at that cancerous tissue, and then treatment is over, they leave. That patient is not radioactive, and they're not a risk to others. Brachytherapy is when there's a radiation source that's put in direct continuous contact with a tumor, that the surrounding tissues get some dose of radiation. The patient emits radiation, and there are potential exposure risks to others. There are solid and sealed implants. There are liquids that are unsealed. If that patient is receiving a liquid form or liquid radioactive medication, their excretions are radioactive because they're going to excrete that, and so that's going to be radioactive. Side effects and risk are generally limited to tissues in the target area. In the acute phase, radiation can affect taste, can cause fatigue, can cause bone marrow suppression. Normal tissue can be damaged. So someone who receives radiation for breast cancer, they may have a lot of skin damage during that time, for example. Radiation can also cause secondary cancers because remember, one of the effects of radiation is damaging those cells, and it may cause abnormal cell division and lead to what we call secondary cancers. It causes dry skin. Long-term, the local skin changes and hair loss because of damage to that tissue may be permanent, but if I'm getting radiation in one area, I'm not going to lose the hair in a different area, if that makes sense. Tissue damage and loss of function. So, for example, if the head and neck are irradiated, the salivary glands may be affected permanently. Okay, the last thing I want to talk about is chemo. Well, not the last, there are a couple more. The next thing we're going to talk about is chemotherapy. Chemotherapy is when a cytotoxic drug is administered systemically, okay? Usually cytotoxic drugs are most effective on rapidly dividing cells, and they affect healthy cells as well as the cancer cells. So the goal is to kill off all the cancer cells while leaving enough healthy cells for the patient to survive. Chemo is poison. We're just trying to poison the cancer enough and still leave the patient the ability to survive. And the reason that's done is because cancer is deadly, okay? So we're trying to kill the cancer. It's also going to cause damage for the patient. It affects bone marrow. If we suppress bone marrow because it affects rapidly dividing cells, that means we have anemia, leukopenia, and thrombocytopenia, okay? Because it affects the formation of red blood cells, white blood cells, platelets. Hair follicles are rapidly dividing. So when we target rapidly dividing cells with those cytotoxic meds, alopecia is an outcome. And the GI mucous membrane. So stomatitis, those sores in the mouth, nausea, vomiting, and diarrhea are common because the lining of the GI tract will slough off. Chemo can be administered IV, orally, can be infused or instilled into a body cavity, can be administered topically or intra-arterially. So there are a lot of ways to administer it. The risk and side effects, and this is going to include some risk to the nurse. Chemotherapy can create risk for the person administering it. So anyone administering chemo needs to have completed an approved chemotherapy course, not only for patient safety, but for their own safety. Okay. Specific protective equipment is used. Most chemotherapy medications administered IV are vesicants. And so if that IV is infiltrated or extravasated, which is another word for infiltrated, the catheter is not in the vein anymore, that medication is going to cause severe tissue damage. It's called a vesicant. And when we talk about extravasated, we're usually talking about medications that are vesicants. Okay. Chemo can cause anaphylaxis, causes bone marrow suppression, causes alopecia, nausea, vomiting, diarrhea, stomatitis and mucositis, those sores on the mucous membranes, appetite loss, skin changes, anxiety, sleep disturbance, constipation. Yes, both diarrhea and constipation. It affects cognitive function, and sometimes people have longer term effects from that. Fatigue. Some types of chemo can cause cardiomyopathy that can cause the muscle of the heart to be weak. We just talked about cardiomyopathy in the last unit. Bring that forward and think about what would that look like for that patient. They can cause neuropathy, which it can be nerve pain or numbness or both. And that neuropathy may be permanent as well. Chemo can cause secondary cancers because of the tissue damage it causes. Another cancer, a different type of cancer, may grow later. It can cause something called hemorrhagic cystitis. The lining of the bladder becomes inflamed and bleeds, okay? And it can cause osteoporosis. That's a lot. Chemo is a lot. Biologic response modifiers they're not chemo. They are a different kind of drug given for cancer. They're specific and targeted, and they may have less toxicity than chemotherapy or radiation therapy. And what they do is affect the way the body responds to the tumor or the cancer. Some of them, for example, will activate the body's immune system to fight that cancer. Bone marrow transplant or stem cell transplant is used for a lot of different neoplastic which is cancer, and immune diseases, the goal is to establish normal blood cell formation, hematopoiesis. Usually it's reserved for diseases that are unlikely to be cured by other means because it's dangerous. So it begins with ablative therapy. Either chemo or radiation is used to completely wipe out the bone marrow and stop any blood cell production. Stem cells are harvested from either a donor. Sometimes people have donated their own healthy stem cells, or there may be stored umbilical cord stem cells. Those are administered IV. They repopulate the bone marrow and begin production of bone cells. It's important that the donor matches to prevent graft versus host disease. The transplanted cells can actually contain antibodies that attack the recipient cells. So what are the risks? In the time when all the bone marrow has been wiped out and the grafted cells have not engrafted yet, so the stem cells have not populated the bone marrow and started working again, in that time, that patient is severely immunocompromised. They also may be severely anemic and thrombocytopenic. And during that time, until they start making blood cells again, they may need transfusions of red blood cells, platelets, and white cells at times, okay? So that's one of the risks. There's severe immunocompromise. They live in the hospital for about 100 days, and they live in protective isolation from the time that ablation starts until their white count is high enough to come out. They can have graft versus host disease when the actual transplanted stem cells contain antibodies that attack the recipient cells. They can have veno-occlusive disease, which they can have inflammation and clotting that affect perfusion, particularly to the liver, and the transplant can fail. So you've killed off all of their ability to make blood cells. You do the stem cell transplant. If it doesn't work, if it fails, they just now don't have the ability to make those. So it is a very dangerous option, but if it is successful, it's curative for a lot of these diseases. The next couple of sections are going to be about some specific hematologic cancers. And again, you get more in depth into this next semester, but we're going to cover hematologic cancers just a little bit.